Galad Hakim, Assistant Vice President. Good afternoon and welcome to our Oncology Lecture Series. I am Dr. Galad Hakim, Assistant Vice President of International Healthcare Partnerships and Insurance Development at Baptist Health. It is my pleasure to welcome all of you to this informative presentation. I would like to extend warm greetings to our friends across Latin America, the Caribbean, and everyone joining us today. During this interactive presentation, you will have the ability to ask questions via the Q&A feature located at the bottom of your screen. I will be your moderator for today's lecture. This afternoon, I have the distinct pleasure of introducing Dr. Ariel Perez. His presentation is titled CD19 Targeted CAR T-Cell Therapy in LBCL, raised to the frontline and evolving role of the cellular therapist. Dr. Perez specializes in hematology and medical oncology at the Miami Cancer Institute, which is part of the Baptist Health South Florida. He is a board certified in internal medicine, hematology, and medical oncology. Dr. Perez is a leading expert in bone marrow transplant, cellular immunotherapy, and malignant hematology. Dr. Perez received his medical training at the University of Medical Sciences of Havana, Cuba. He completed his internship internal medicine residency at Orlando Health, followed by hematology oncology fellowship at the UF Health Cancer Center in Orlando Health. He served as a chief resident and chief fellow during his residency and fellowship program. Dr. Perez earned several academic achievement awards, including the Internal Medicine and Hematology Oncology Academic Achievement Award at the Orlando Health, and graduated medical school with honors, summa cum laude. Dr. Perez joined Miami Cancer Institute from the H. Lee Moffitt Cancer Center and Research Institute in Tampa, Florida, where he completed a fellowship in bone marrow transplant and cellular immunotherapy. During his fellowship, he was involved in clinical research in CAR T-cell therapy for patients with relapsed refractory B-cell lymphoma. Dr. Perez is a member of several professional associations that includes the American College of Physicians, the American Society of Clinical Oncology, and the American Society of Hematology. His research has been published in peer-reviewed publications, including blood, transplantation, and cellular therapy journals, Journal of Clinical Oncology, Journal of Thoracic Oncology, and also of Oncology. He has also presented his research at numerous research meetings, industry conferences, and events nationally and internationally. Dr. Perez is, of course, fluent in English and Spanish, and I would like to welcome you, Dr. Perez, and thank you for accepting our invitation to today's presentation. The floor is yours.
Thank you so much, Dr. Hakim. It's a pleasure to be here and talking a little bit more about CD19 targeted CAR T-cell therapy, how these adoptive cellular immunotherapy products are moving forward into the front line in large B-cell lymphoma. And as cellular therapies, what's our role in these therapies and how can we improve our patient outcomes with adoptive cell therapy. As background, diffuse large B-cell lymphoma is the most frequent non-Hodgkin lymphoma subtype. It's usually diagnosed in patients over the age of 60, and the majority of patients have stage 3 or 4 disease. The current standard of care is for frontline therapy is chemoimmunotherapy with Rituxan or a similar medication targeting CD20, along with an anthracycline backbone of chemotherapy like R-CHOP. The cure rates with this approach are between 50 and 60%. Relapsed large B-cell lymphoma poses a difficult situation, and the current standard of care in these patients is to do salvage chemotherapy with platinum-based regimens, and if the patient responds, meaning achieves a complete response or partial response, then we proceed to high-dose chemotherapy with an autograft rescue or autologous stem cell transplantation, in other words. As some background, this randomized study called the CORAL study that compared two salvage regimens, RDHAP and RICE, with the goal of taking patients that obtain a CR or a PR to autologous stem transplantation with being conditioning. And this study, I want to highlight that of 200 patients of each arm that were randomized to either RIs or RDHAP, half of these patients received autologous transplantation. So we already said that the frontline therapy cures about 50 to 60%. Of those that are eligible, that had not a good outcome from frontline therapy or who relapse, then the goal is salvage them with chemo and taking them to transplant. Half of those patients only are the ones that eventually get transplanted. Here are the results per the CORAL study in terms of overall survival and progression-free survival. We would expect better outcomes, but as we can see, the 3-year progression-free survival is 37%. This is on the intention to treat population, so all comers, all patients that were randomized. And the 3-year overall survival is 49%. So again, about half the patients are alive at 3 years. For patients who underwent autologous stem cell transplantation, the 3-year progression-free survival was 53% in this study. So that study that we just shared was published on the Journal of Clinical Oncology in 2010 and includes patients that were treated previously. So what's more recent data on outcomes of patients undergoing autologous stem cell transplant for diffuse large B-cell lymphoma that has relapsed. This is CIBMTR data from the decade from 2008 to 2018, over 1,200 patients, 12,000 patients, sorry. And the 3-year probability of survival was still around 68% for patients that underwent transplant. So these results are good, but we are seeing, when we look at the trends of autologous stem cell transplant for diffuse large B-cell lymphoma in the US, this is, again, CIBMTR data. If we notice here in the lower graph, which is the diffuse large B-cell lymphoma autologous transplants, we know that by the end of 2017, we noticed a significant decrease in the amount of transplants that were performed in the United States. In fact, around a 45% decrease in the number of autologous stem transplants. And this coincides with the approval, the Food and Drug Administration approval of the first CD19 CAR-T product, axicabtagene ciloleucel, or axi-cel. And we could say, is this a trend in all diseases, or is just a trend for diffuse large B-cell lymphoma? The amount of autologous transplants as a whole is going up. In this specific disease, there's a significant decrease. And we mentioned already potential reasons. This is a very interesting study presented by Dr. Shah at ASCO 2020, where data from CIBMTR was analyzed and patients were divided between early chemotherapy failure within 12 months or late chemotherapy failure, meaning more than 12 months, and supports the role of autologous stem transplantation in relapse diffuse large B-cell lymphoma. Interestingly, the progression-free survival rates at 5 years between these two groups, patients with early chemotherapy failure, which usually do worse, compared to patients with late chemotherapy failure, the 5-year PFS was 41% in both groups. Okay, so the initial difference that you see at around 1 year, over time, the two groups' outcomes were balanced. And this is a very interesting question right now in the field of transplantation for diffuse large B-cell lymphoma. So patients that get salvage chemotherapy and achieve a complete response, we take to high dose chemotherapy and autograft rescue, no question. But is patients that achieve a response to this therapy but achieve only a partial response, do we still, the best outcomes are if we treat them with transplant? And as we can see, this analysis, again, by Dr. Shah, that was just published on Blood, we can remember our graph, a cartoon from before, where we see the downward trends in autologous stem cell transplant. And we see that for patients with early chemotherapy failure, this graph looks exactly the same. And these are the estimates for progression-free survival and overall survival among patients in this study. As a brief recap, for relapsed refractory large B-cell lymphoma, patients that are considered transplant eligible and we have this subgroup of patients that have primary progression or early relapses after chemoimmunotherapy, and we give them salvage. The response to salvage is still poor, 30 to 40%. Of those who respond and get to transplant, eventually 50% will relapse. And we know that those patients that relapse in the first 12 months after transplant carry a worse prognosis compared to those where the relapse occur later on after receiving their autologous transplant. And we also have a population of patients due to advanced age and comorbidities mostly, where transplant is not an option. And the question comes, what's the outcome of this population? What's the historical data where the CAR T third line outcomes should be compared to? This study called Scholar-1, published in Blood, identified patient level data from 4 sources: MD Anderson Cancer Center, the University of Iowa Mayo Clinic Lymphoma Specialized Program of Research, and 2 large phase 3 trials, the CORAL study that we discussed and the Canadian Cancer Trials Group LY12 study. And patients that had progressive disease or stable disease after 4 cycles of R-CHOP, patients that had relapse and when we gave them salvage only achieved a stable disease or progress. Our patients that got a response to the second line got transplanted, but then relapsed less than 12 months from their transplant. And their outcomes are actually very poor. You can see the response rates, which are full objective response rates of only 26% with a CR rate of 7%. The median overall survival for patients in this study was only 6 months, and only 20% of patients were alive at 2 years. And this is the data that we should use as a comparison for the pivotal phase, the pivotal third line CAR T trials. So what do we call the CAR T cell era in terms of large B-cell lymphoma and CD19 targeted CAR T products? Around October 2017, approval of Axi-cel, in May 2018, Tisa-cel, and early 2021, approval of Lisa-cel. So those are the 3 products that are approved by the Food and Drug Administration in the third line for relapsed large B-cell lymphoma. I just highlighted a few of the difference in terms of these products. Axi-cel has a co-stimulatory domain that is a CD28, and both Tisa-cel and Lisa-cel have co-stimulatory domains of 4-1BB. And toxicity in this product is higher compared to these other 2 products. And this is an inpatient-only product versus these other 2 products can be done in the outpatient setting. In terms of the vector, this is a retroviral vector compared to lentivirus. And then there's difference in the lymphodepletion. And this is an important step. So the process of CAR T cell therapy involved administering chemotherapy with a combination usually of fludarabine and Flu-Cy for 3 days. And then that's prior to the infusion of the product. The trial that led to the approval of Axi-cel was the SUMA-1 trial. The trial that led to the approval of Tisa-cel was the Juliet trial. And the trial that led to the approval of Lisa-cel was the Transcend trial. Here are the estimates, the Kaplan-Meier estimates for these main 3 trials. And I just want to highlight that independent of the study that you looked at, you're going to see this type of survival curves where you see a tail at the end, and this tail hangs around 40%. So current data from all of these studies suggests that CAR T cell therapy can lead to cure in patients with relapsed refractory lymphoma in approximately 40% of the patients. And you can see the survival curve for each of these studies shown in the slide. This is, when we look at trial data, we always see when this was done in the context of a clinical trial. And the external validity of these studies is always that something that you have to worry about, like how in the real world, how much of this data can I duplicate if I just doing it on my regular day-to-day practice. And this is real world data from Axi-Cell in the third line setting from the US consortium, and it included 298 patients that underwent leukapheresis for planned standard of care Axi-Cell. And there's the consort diagram, and some of the patients received Axi-Cell as standard of care, most of them, and only around 7 patients were included on the SUMA-9 study, which is basically for when the product fell below the manufacturer specifications, okay? These are the progression-free survival and overall survival curves for Axi-Cell in this real-world study. Median PFS of 8 months around, median overall survival was not reached. And as we can see, 12-month progression-free survival of 47% and 12-month overall survival estimate of 68%. Obviously, we have to stay away from comparing different studies and different trials. From a scientific standpoint, it's not ideal. But if we take a look at the overall survival in Scholar, and we look at these numbers, we can see how much of a game changer the introduction of CAR T-cell therapy has been for relapsed refractory large B-cell lymphoma patients. This is a real world from another product, the Tisacel product in the third line setting. Remember, we talked about the approvals. One was in 2017, the other one early 2018. So for those two products, we have real world data. And this is comparing CIBMTR reported outcomes to the outcomes of the pivotal trial, the Juliet trial, and progression-free survival, duration of response, and overall survival, and are similar between real-world experiences with this product and the trial data. This is the 6 months and PFS and overall survival rates, who were 38.7 and 70.7 respectively. And as you can see in the progression-free survival curve, there's a flattening of the curve. For Lisa-cel, which was the last product that was approved, we still don't have any real-world data to discuss with you since it was a more recent approval. And the next step is, like, we have discussed the data on the third line setting. Now we have to talk about what happens if you keep moving forward with this CAR T products in the large B-cell lymphoma treatment sequence. And I think this meeting that happened in December, the American Society of Hematology meeting from this December, was heavily rich in studies about large B-cell lymphoma and specifically in CAR T-cell studies. So the SUMA-7 study was presented by Dr. Locke in the plenary session. It's a randomized, these are all randomized studies. There's some difference between them, and we're gonna just highlight that in terms of their primary endpoint, event-free survival was the primary endpoint in all studies. But the definition of event-free survival, and as you can see, was different between the SUMA-7, the Transform study, and the Belinda study for Tisacel. These two studies, both the SUMA-7 and the Transform studies, met their primary endpoint. So they showed a significant benefit in terms of event-free survival prolongation compared to standard of care. The Belinda study did not meet their primary endpoint. And when we say these studies compared to standard of care, the standard of care arm in all of these studies was salvage platinum-based chemotherapy, followed by autologous stem cell transplant in those patients who responded, okay? This is modified from the consort diagram of the SUMA-7 study that was just published in the New England Journal of Medicine. And one of the comments on this study that has been brought up repeatedly was about the fact that if you look at the amount of patients, 168 patients receive at least one dose of salvage chemotherapy. But if you look at the percentage of patients or the amount of patients that receive the actual transplantation was 62 out of 168. And I don't think this is far from what happens in practice in terms of how many patients you take to salvage chemotherapy that can eventually get transplanted. And I didn't mention in the trials, but in the trial slide where I compared the 3 studies, but these studies were heavily enriched with patients that had primary refractory disease. They all included patients that had relapses up to 12 months, but they were enriched with the primary refractory subgroup of patients. This is the event-free survival curve. Remember, this is the primary endpoint of the study. There's a significant benefit of axi-cel compared to standard of care. And as we can say, this is a fairly large randomized studies with 180 patients in each arm, approximately. And the follow-up for this study was 24 months. So I think enough follow-up, size, randomized study showing that event-free survival is significantly better in patients that undergo axi-cel in the second line compared to standard of care with salvage chemotherapy followed by autologous stem cell transplant in responders. The question is, does this translate into an overall survival benefit or not? And which subgroups will you select for this therapy, if any? So as you can see, this is the forest plot for the study. And in all subgroups, regardless of age, response to first-line therapy at randomization, EP, specific subtypes like double hit or triple hit, double expressors, in all subgroups, axi-cel perform better compared to the standard of care. These are the Kaplan-Meier estimates for progression-free survival and overall survival. Again, progression-free survival was significantly better in the axi-cel arm. And in terms of the overall survival, I just want to note that this was not significant, but if you look at the 95% confidence interval, the upper limit lays like right across 1. So with additional follow-up, maybe we see some changes in the significance of this overall survival findings in the study. The transform data basically also met the primary endpoint. And as we can see here, the median EFS and PFS in this liso-cel study was significantly longer, and the CR rates were also improved. The overall survival data, the follow-up on the transform study is shorter than the follow-up on the SUMA-7 study. So at this point, the data was immature to make a conclusion about overall survival. In terms of safety, and I didn't highlight safety in the SUMA-7 study. We already mentioned briefly that is the toxicity of this product is a little bit higher, and CRS rates, severe CRS rates, grade 3 or higher, are between 7 and 10%, and severe ICANS around 30%. In the case of the liso-cel study, toxicity is lower, and there was no new safety signals when we're looking at this second line study compared to third line data. And then we don't have a lot of information, published information about the Belinda study, but it was presented as a late abstract in ASH this December. And unfortunately, this study did not meet its primary endpoint in terms of EFS. So between the 3 products, this was the only one that failed to meet the primary endpoint. We mentioned that this could be related to trial design differences between this study and the other 2 studies. And there's also some data coming up from, there's a presentation from the Descartes, the French registry data, And according to the patterns of use, there's also some signals that maybe T cell may not be, the efficacy may not be the same. But I think here mostly design played an important role in not meeting their primary endpoint. So moving forward, can we still move forward with CAR T more than just second line? And also at ASH, there was this presentation by Dr. Nilapu of SUMA-12, in which basically high-risk large B-cell lymphoma, and this was defined by histology. So if you had a double hit, which means MEK and BCL2 and or BCL6 translocations, or an EP score more than equal or higher than 3, plus a positive PET after 2 cycles. So these patients still get frontline chemoimmunotherapy, anthracycline base, but instead of letting it play out, we use PET-CT to identify those with higher risk disease. And if they had a PET that was Dubile score 4 or 5 after 2 cycles, then they went on to this study. And as we can see, the responses with axi-cel in this high-risk population were very encouraging. There's an 89% objective response rate, 78% of patients achieve a complete response, and most patients achieve an objective response. The question arises, well, is there, they have enough follow-up? The patients with more than 12 month follow-up, more than 60% of the patients, and the median time to response was very short, and there was significant amount of patients that converted from a partial response or stable disease to a complete response. And I found this also very interesting to highlight, because we are now talking about effector to tumor ratios, and how important is the expansion of these CAR T cells when you balance them against the tumor burden in patients with lymphoma. And as we can see, if you compare SUMA-12, where you're talking about patients that got 2 cycles of therapy, compared to SUMA-1, where the median numbers of prior lines was 4, and you look at the expansion of this CD19 CAR T cells, and we look at 2 different ways, peak CAR T expansion and AUC, but you see that patients in the SUMA-12 study compared to SUMA-1 had higher expansion of their CAR T cells. And if you try to balance the fact that if you had to find an inadequate CAR T cell expansion to overcome tumor burden, that may be one of the explanations of the better results observed when you move earlier on the therapy sequence with CAR T. This is a very interesting paper by Drs. Jane and Spiegel from Moffitt and UM respectively, where they go over what the future of the cell therapies looks like, and how much can we do to improve patient outcomes in this subset. And I like a lot the analogy of, like, if we're talking about cars, how can we better drive this car? So it's not just about giving lymphodepletion and giving the therapy. It's how can we work on the pre-CAR T scenario? What do we do before we give the patient the therapy? What better ways are of quantifying the antigen, on quantifying the target? In these studies, most of the tests that were done were immunohistochemistry for CD19. Do we move to quantitative flow? Do we assess aspects of the tumor microenvironment in the patient that can affect the efficacy of the CAR T cells? Then obviously the phase of the manufacturing, can we make this process more efficient? How can we have better CAR T cell products? We know that the quality of the CAR T cells that we put into the manufacturer impact the final product. So, and then what do we do after we actually give the product? How do we monitor them? We monitor the immune response to lymphodepletion. Do we have better ways of looking at circulating tumor DNA and intervening earlier in those patients that are at a higher risk of relapse. And there's a subset of patients that at day 30 have a partial response or stable disease, and then at day 90, they can have an improvement of their response to a CR. But the majority of patients, longer the time passes, if you don't achieve a complete response, the lesser the chances are of having a good outcome from CAR T cell therapy. This is how I think it's gonna look in terms of the relapsed refractory large B-cell lymphoma landscape. And the question is, how do we get these building blocks into your patient? Which one? And these are not all applicable to the same patient. For example, the L-MIND study that with tafasitamab and lenalidomide was in the transplant ineligible population. So it doesn't mean that you can use all of these blocks in the same patient, but how to sequence these therapies is gonna become more complicated, and definitely is a space where we need more data. So we have, I think, a preponderant role for CAR T cells, but we also have antibody drug conjugates like loncastuximab. And we have, these are not FDA approved, the bispecific T cell engagers, but we have several products that are molecules that are in clinical studies that are very encouraging results. Mosun, belfitamab, odronextamab, epcoritamab. So all of these are the tools that we are going to have, not only as cellular therapists, but as hematology oncology to deal with these patients. And I think it's a good thing for them that these building blocks keep growing, and that we have data about using not only this new adoptive cell therapy or CD19 targeted CAR T cells, but all these armamentarium of interventions. So thank you so much for your attention. I'm gonna let Dr. Hakim take it and see if anybody has any questions.
What a phenomenal presentation. This is so exciting, especially for us at Baptist and Miami Cancer Institute, to know that we have the caliber of physicians in your team, together with Dr. Kona, who was the promoter of this phenomenal program. We're really, really thrilled and excited to read the outcomes of all your patients. So with that, I wanted to just ask you, in the meanwhile, hopefully we'll get some questions from the audience. How long has the program been already with MCI? I lost count.
2 years or more.
2 years already. And how many patients have we treated so far?
Well, in the setting of CAR T, we treated patients that were enrolled on study with mostly the Lisa-cel product. Okay. And hopefully we'll get some commercial CAR Ts going soon.
That's phenomenal. In total, do you recall how many patients so far that have received?
In total, I don't recall how many patients. In terms of CAR T, I would say they are in the around 10 or more. But in the terms of transplant, yeah, much more. In terms of autologous transplants and allogeneic transplants.
Yeah, I wish our colleagues from the different countries could actually see your area, the bone marrow area, because it's actually something really superb, and the technology behind it, it's absolutely magnificent. Doctor, when we receive these kinds of cases from abroad, we typically ask several questions, one of which, has the patient been recently diagnosed, or has the patient already started treatment? Would that be a hindrance if the patient already started treatment? Let's say you get a mantle cell type patient. Would that be a hindrance if they already started treatment abroad for you to consider him for CAR T?
No, not necessarily. In fact, the approval now is for previously treated patients, and the only considerations will be sometimes in the relapse refractory setting, some of the therapies can have an impact on T cell fitness. So we would have to coordinate. For example, bendamustine exposure has been linked to difficulties called, like getting a good product in terms of T cell fitness. And one of the regimens that you can use in relapsed refractory large B-cell is BR-POLA. So we can, talk to the treating physician and maybe just do the polatuzumab with the Rituxan and, avoid the bendamustine if we are planning on seeing them and collecting them and that type of situations. But the prior treatment, there's not a limit of lines in the current label. In any case, you have to have a minimum, not a maximum. So you have to have at least 2 prior lines in the current label to qualify for CAR T. But there's no maximum. In fact, it's very frequent to have patients that have gone 4 or more lines of prior therapy prior to CAR T.
Now, these patients, obviously, we don't. I don't recall the criteria, but there is no age limit. In essence, an adult or a pediatric population is welcome to actually be evaluated for CAR T. Is that correct?
Yeah, so we deal mostly with adults, although some of these CAR T products in ALL, for example, the initial approval for T-cell was up to age like 25, and now, that's expanding. But in the setting of lymphoma, it's for adults, and there's no upper age limit. In fact, I have seen patients in their 80s getting CAR T-cell therapy. Obviously, product selection is key. Like we mentioned, not all are created equal. So some of the products have higher toxicity and some have less toxicity, and some specific scenarios, including advanced age or renal function, or patients with specific involvement of extranodal areas like gastrointestinal tract or CNS. You can decide which product fits with patient best, but I see the age limit are probably less strict than for transplant. Like I would say I feel more comfortable taking a patient to CAR T than taking them for high dose chemotherapy and autograft rescue. Even if they are frail. And the other advantage is that you have different options. You can tailor what you do based on the product to the patient.
So in essence, if we were to accept a patient from abroad to be brought into Miami, you expect that patient to be hospitalized, I assume, for a period of time. Do you start them on chemotherapy before you start CAR T? How does that work in essence?
We can do the as an example the product that's more involved in terms of inpatient stay, which is Axi-cel, because the toxicity is a little bit higher, and they will have to be admitted on an average, I would say, around 2 to 3 weeks, okay, between the lymphodepletion, and then you have to keep them for monitoring of toxicities. These products have inherent toxicities, immune effector cell mediated, like cytokine release syndrome and neurotoxicity. And the onset varies according to the product. But yeah, I would say this first 2 weeks after product infusion will be the most critical time in general. And then the lymphodepletion, like we mentioned, is 2 agents for chemotherapy that are done for 3 days prior to the infusion of the product on day 0.
So you did talk about the remission period or the success rate of these particular types of therapy. Can you recapitulate for us? What is your experience in regards to the success rates for?
I think the success rate long-term across products and across all the scenarios, I would say, is around 40%. Okay, but the comparison, and that's what we were talking about only their median overall survival was 6 months. So now we are talking about people, 40% of patients that had a median overall survival of 6 months. Now you have 40% of patients that are alive at 2 years, and consider to which point you need to do something after CAR T. That's where I think we're gonna have to need more data. How do you identify those patients that can fail? But most patients that achieve a CR at 6 months, they actually remain in remission. So if you go past that initial period and you're looking at 6 months down the line from product infusion, if you are in a CR, in a complete remission, most likely you will remain in a complete remission.
Wow, that's very encouraging. Now, one last question. Would you consider a second CAR T type treatment for a person that already received it and had some decline or something? Is that something that we typically do?
I wouldn't say typically. It depends a lot on the pace of the disease, the type of product that you use initially, how long was the response after that initial CAR T infusion. There's certainly data for repeat infusion and large B-cell lymphoma. How does that compare to another alternative treatment? That would have to be, patient by patient decision. And obviously there's no data for is second CAR T better than doing something else of this list of therapies that we will go. I think one of the main challenges now is how to sequence therapy, because as you see, the CD19 as a target is something that keeps repeating. Different platforms, antibody drug conjugates, CAR T cells, BiTEs, but the CD19 is one of the main targets. So how to sequence these therapies and get the best outcome for patients is definitely an area to look into.
That's phenomenal. Now, if I was to ask you, Dr. Perez, what are you most excited about in regards to this technology and in the future of this technology?
I think one of the things that excites me is that we're going to be, the fact that we're saying chemosensitive and chemorefractory, those terms I think are going to go away. This field of adoptive cell therapy and in general immunotherapy in cancer is going to change completely the way we looked at fighting cancer and telling patients what the best way is to proceed. So we're looking currently at third line. So patient has to have 2 or more lines. And we're seeing the studies, the way I review them, that we're talking like if a patient after 2 cycles of therapy, you see that they're not going to do well, then that's the time to intervene. Obviously, more studies are needed. And the SUMA 12 was like 40 patients. So we cannot make that this is going to be the new standard of care right now. But I'm very, very excited to see that these products are moving forward. And then, yes, it's a treatment that's very involved. It has the advantage as well that it's a one-time thing in most patients. So it's not a chronic therapy, because obviously when you look at cost effectiveness analysis and all of these other issues, it is a one-time treatment that has a higher cost, but the other alternative also are like chronic therapies that you have to do until progression of disease in most of them. So you have to be receiving treatment all the time.
Correct. And also deal with the sequelae of the actual treatment. Sometimes the treatment becomes a little bit more detrimental than curative in essence. So that is extremely, extremely exciting for all of us in the field. Yeah, definitely. The cost is sometimes prohibitive for some people, some patients. Obviously, it drains resources, as we all know, and it's because everything at this point is considered somewhat experimental. In the United States, for the audience that is from abroad, Medicare does cover part of this particular treatment, and some insurance companies as well. So we have had some patients from abroad. So if you do have any patients that you would wish for Dr. Perez to review, we will be more than happy through our international department, have him review the case and see if they qualify. Obviously, one of the caveats is that they have to stay not only for the period of the treatment, but also for the follow-up. Typically, a month or 2, we tell the patients that they need to be available for him and for the team. Dr. Perez, we are so excited for the future of CAR T-cell. We welcome all the research and the hard work that you and your team are currently exploring. And we look forward to sharing this with our peers abroad. And with that, we're going to go ahead and let you go so you can continue your clinic. And on behalf of our entire international team, thank you once again for that phenomenal presentation, and to all of you for attending and participating in today's event. If you have additional questions about today's presentation, please feel free to email them to BHIWebinars@baptisthealth.net. That is BHIWebinars@baptisthealth.net. We will make sure to forward those questions to Dr. Perez. He will elaborate on them, and then we will forward the response to you. If you do have any patient that you would like to have a review, a case review, send it to the same through the same email or at international@baptisthealth.net. That way we can just process that particular referral for Dr. Perez. Once again, we look forward to seeing you at our next oncology lecture series, which we scheduled for April 6, 2022. In the meanwhile, thank you once again. Please stay safe and have a great afternoon. Thank you so much, Dr. Perez. Have a great weekend.
Thank you. Thank you so much.
Bye-bye.